Welcome everyone to the webinar. This is my first time doing this, so bear with me, please. What we're going to try and show today in this short 25-minute presentation is that obesity is a highly complex chronic condition, and it also relapses. In many respects, relapsing or weight gain can be somewhat inevitable, as the body's homeostatic forces try to fight weight loss, and we'll be covering a bit more about that later in the presentation tonight. What we do know about obesity is it's quite easy to screen. If you ask most patients, they'll be able to tell you some idea of their weight, their height, from which you can calculate their BMI, and most people have an idea of their waist circumference as well, and you can use these three measures to stratify risk. However, quoted and measured values are not they don't always equate. If we look at the scope of the issue, over the last 30 years, BMI and weights of the population have been increasing, so much so that it's increased about 50% since 1970, with now in Australia about 80% of people being overweight or obese with a BMI of greater than 25. And if we look at these two particular graphs here, one looking at children and one across the scope of the age ranges, we see in this area where we have the blue arrow here, this denotes people who are children in the 1970s. And at this point, around 10% of children were obese. If we look at this same population of people who are now in their sort of 55 to 65 range, we see that these same group of people have obesity or overweight rates of around 80%. And the important point to make about this is not only what's happened to these people, but what's going to happen to the people who are children now. Obesity rates in children already are approaching 25 to 30%. And when these children become adults in around 2050, we're going to have much higher rates of obesity. And these children are going to be exposed to obesity for a much longer period, meaning that the effect of chronic disease will be greater. If we look across the current age distributions of the Australian population, we see that the 55-year-old plus are now the most overweight proportion of the Australian population, and also have the highest rates of clinically significant obesity. And what we know is that now smoking rates are declining. The increasing age and obesity is the highest contributing factor to chronic disease and health expenditure, with currently around $5 billion a year being spent on obesity and its side effects. If we look back at a study that was published in 2014, looking at the longitudinal effects of obesity, we see that in 2014 there was predicted proportion of people with a BMI over 25 of about 60%. And what this graph tells us, and what I've drawn on here is actually the actual increase we've seen in the last 5 years, is that we've actually done nothing about obesity in the last 5 years. We haven't tackled it, and in fact the situation is rapidly becoming worse. It's not necessarily without notice, but it is without progress. In terms of the worldwide obesity pandemic, we've got to think about what's changed over the last 30 years. Is it that we've lost self-control or self-regulation? Has something changed in the human psyche over the past 30 years? Or there are other factors at force? And these factors are largely market forces. If we look at two things which I feel have contributed to this from an economic point of view, it's corporate greed and the chasing of the tax dollar, and the reluctance of the governments to rein in the corporations due to government's reliance on the tax dollar received, jobs created. And we've had poor funding on food education and poor funding relating to preventative medicine as well. And this isn't just an Australian problem. This is happening all over the world now. This used to be a disease of developed nations, but if we look over on the graph on the left-hand side, we see that China now has very high levels of obesity in its population. And also, if you look across the developing and non-developing areas of the world, massive increases in levels of obesity in nearly every area around the world. And this not only is a worldwide problem, this is reflected in our Australian population as well, with migrant communities often having lower levels of obesity compared to the Caucasian equivalents, and they're rapidly catching up. But as clinicians, we can't really treat a whole population. We can only really treat the people who are presenting to us. And we could really spend the whole of this presentation just talking about this slide. If you think about your own populations and the own areas of work, you'll have different levels of education, social and environmental factors, and they'll be specific to your own practices. The things that I think play a very large role in an individual's risk of becoming obese are these functions here. Bit of a messy picture, but what we're looking at is the psychological factors, the biological factors, and especially the epigenetic factors. Behavioral factors have a large cause, and obviously social factors and education play a large proportion, or contribute a large proportion. The other thing that really isn't on this is psychiatric illness, with high proportions of people with psychiatric illness now having obesity as well. If we move on from the scope of the problem to what are the side effects of diabetes, and this is largely split up into three main categories. Chronic disease, and we're all fairly well aware of this, with you know, both cause and effect of obesity being proven between cardiovascular disease, diabetes, lung disease, reproductive problems, and especially cancer. And what we know, if we actually can reverse obesities, we can reverse the risk of developing these chronic conditions or stop them progressing. But what I want to talk a little bit more about today is the functional and psychosocial disability that comes with obesity, because these are really some of the factors whereby people are coming to their doctors to seek help. So we spend a huge amount of tax dollars correcting orthopedic and spinal issues each year, and in many cases weight loss can alleviate the need for arthroplasty, or certainly delay it by a number of years. Toilet issues, difficulties maintaining personal hygiene, and sexual issues are often reasons why people want to talk to their doctors about losing weight. And also, we also often see people's interaction with their environments being a big stimulus to requesting change. And this can be simple things like putting on a seatbelt, going on a bus, or using public transport. And these are often seen by patients as a bit of a wake-up call. What we also see in obese patients is they have worse outcomes for non-obesity related conditions, and in my world, a lot of non-obese related surgical conditions, their outcomes are poorer. In terms of psychosocial distress, obese people have are much less likely to complete their education. They're more likely to earn less money, and they're often discriminated in employment as well as in healthcare as well. Obese patients have generally have been measured to have lower quality of life and poor self-esteem. And around 50% of people seeking counselling for bariatric surgery have a history of mental health problems. Around 10% of people have social anxiety, and depression is around 5 times more common in obese individuals, with a lifetime risk of about 50%. One of the issues here is that really society hasn't really changed, and it's still seen as obesity really is the sort of last form of discrimination, with social ideals still being thinness. And really in the media, all forms of discrimination apart from against obese individuals is largely left the media. So if we move on now to think about what we can do and how weight loss can make a difference, even small or relatively modest reductions in total body weight can lead to improved health outcomes. But for people who are more obese with class 2 or 3 obesity, those who've been obese for a long time, and those with active chronic disease, greater weight gain is needed to affect change. An ideal weight loss program should be sustained and non-reversible. And the factors that influence the success of programs are being whether they can be ongoing and intensive, have a strong focus on education, those that are considerate of people's family and well-being, and also in no small amount have some element of psychosocial support. And it's often thought or said that curing overeating or weight loss is a lot more difficult than treating alcoholism or drug addiction, because you can give up drugs or alcohol, you can't give up food, you still need to eat. So a lot of this starts with starting the conversation, and this is actually an excerpt from the Australian Family Practitioner about a pro forma of how you approach these patients. And it's really, to my mind, all about starting the conversation. How do you start this conversation, and what sort of questions can you get into to get into the subject? And it'd be interesting if you could provide some comments of how you as general practitioners first broach this question. But it's often a question of something like, would you like me to talk to you about your weight, or would you like me to talk to you about options for losing weight? In my practice, I often sit there with a patient who's quite morbidly obese, and I find it even myself in the non-bariatric sense to initially broach this subject with patients. In brief, the pro forma comes along as first of all, you have to ask and start the question. You have to assess the patient, like we saw in the first slide, and then advise, assist. And it's only really late on in this pro forma that you consider really referral to a specialist weight management clinic. So if we look at what you can do with weight loss programs, and this is probably before the weight loss clinic or in conjunction with a weight loss clinic, we can see that you can actually achieve quite significant weight loss with medical therapy. And the highest on this graph, we can see around 16 to 18 kilos of weight loss achievable with very low energy diets, something like an OptiFast, although as you can see from the graphs, quite difficult to sustain. Sibutramine or Reductor is now off TGA in Australia and can't be used anymore. But we see some of the other medications like Xenical producing fairly modest but somewhat sustained weight loss management. And then the sort of newer drugs such as Duramide, which is an amphetamine-like appetite suppressor, and Saxenda down the bottom. Some of the issues we do have with these medications is they do produce fairly moderate weight loss, and it's usually over a short-term period with a tendency to weight regain. One of the things to note from this graph is just providing advice alone or a diet program alone is rarely highly successful. So what about endoscopic methods to assist weight loss? Over here we have an intragastric balloon, which is a procedure which takes about 15 minutes to place the balloon and inflate it. The idea with the intragastric balloon is it can stay in for around 6 months at a time. Some of the newer ones can stay for longer. It's easily reversed and it's easily adjusted. It's kind of akin to what happens with a laparoscopically assisted gastric band. It can be assisted to the patient's symptoms or the patient's weight loss. But one of the problems with this method of weight loss is that having the patient be able to control or somewhat control how much restriction they get can lead to problems over the long term with sustaining weight loss. And if you think about what we really want to aim for is sustained weight loss over a lifetime, having a easily reversible procedure doesn't quite fit with that bill. The other device that's available in Australia now is the Aspire Assist, and this works by basically placing a peg tube into the stomach, and after a patient eats or overeats, they're able to remove some of the calories and some of the food from the stomach. I really don't like the idea of this, and really, to my mind, this is a kind of sort of, medically supervised bulimia. The new kid on the block is endoscopic sleeve gastroplasty, and we're often asked about this procedure and how does it compare with traditional weight loss surgery. It's performed by placing a number of stitches endoscopically in the wall of the stomach to try and reduce the volume of the stomach and act in a restrictive nature, and again can be performed as a day surgery with quite low morbidity. This paper is looking at the outcomes of endoscopic sleeve gastroplasty versus sleeve gastrectomy in laparoscopically adjusted gastric bands. And these graphs are a little bit difficult to understand, that's why I've colored them in. But what we can see here is that these groups are not quite equal. If you look at the LSG, the laparoscopic sleeve gastrectomy, these patients are a lot heavier than the endoscopic sleeve gastroplasty to start with and have much, much higher rates of chronic disease. I like to think of this, well, if this patient was me at my height, I'd be starting off here at 155 kilos. And if I was starting off here, I'd be starting off at 125 kilos. So over the course of 12 months, I'd lose 15 kilos with an endoscopic sleeve gastroplasty and around 45 kilos with a sleeve gastrectomy. What you can also see on this graph is that even after 9 months, the patients with the endoscopic sleeve gastroplasty are starting to regain weight again. And if we look at the total weight loss over 12 months, we see that in the lap band and endoscopic sleeve gastroplasty group, we achieve about 15% of total body weight loss, and this compares to about 30% in 1 year with a laparoscopic sleeve gastrectomy. But these are very short-term results, and if we think about comparing sort of medical therapies versus surgical therapies, this is an excellent study from Sweden, and this is a longitudinal controlled study looking at a very, very long time point over 20 years. What we see with these is that those in the surgical group and in the medical group initially lose weight. It's rather different amount of weight, but everybody over time tends to put weight back on and then it stabilizes out. What you can see in this first graph of weight change is even if you do regain weight, with the surgical options, you're still having a 20% reduction of your BMI over the long term, over a 20-year period, which is quite remarkable. And this really equates, again, comparing medical therapy to the overall mortality in the surgical versus non-surgical patients. And you're essentially have a hazard ratio of a 0.7, so you're 0.7 times less likely to die within the study period. If we look at other endpoints for this study, not only mortality, but cardiovascular events, your rate of developing cancer is 2/3 if you undergo obesity surgery compared to best medical therapy. And prevention of diabetes, these are people who didn't have diabetes to start with, but over the course of 20 years developed diabetes. You're 5 times more likely to develop diabetes if you're obese and you have medical therapy versus surgical therapy. So if we move on, having just talked about diabetes, to look at the topic of insulin resistance, we know that people with class 2 obesity are 93 times more likely to develop type 2 diabetes. And 85% of people who have type 2 diabetes are obese, although only a relatively small amount, only 20% of people who are obese have diabetes. How does this work? Well, you get laying down of visceral fat and the visceral fat causes an inflammatory response that frees fatty acids and pro-inflammatory cytokines. And these, among other things, inhibit cell signaling. They inhibit the insulin response in skeletal muscle, and also this release of triglycerides and glucose from the liver causes further beta cell damage, laying down of fat in the pancreas and liver, which we call steatohepatitis or steatopancreatitis. And really, when people get to the point where they have poorly controlled diabetes, this is a vicious cycle. If we look at conventional treatments for diabetes, some are associated with weight loss and some are associated with weight gain. It's fairly well known that treatment with metformin as a single agent will produce modest amounts of weight loss. And some of the newer agents, such as sodium glucose cotransporter 2 inhibitors, associated with higher weight loss, and in some studies a reduction of 38% in cardiac events as well. On the other side of the scale, the requirement for insulin contributes to the complications of diabetes, although it will control blood sugar. And as people have poorly controlled diabetes, the risks of chronic disease and complications secondary to that increases. So if we look at another study looking at medical therapy of diabetes, and this is best medical therapy in a randomized controlled trial, very well regulated, and compare that to surgical therapy, what we see is in the medical group, there's around a 13% reduction in the need for insulin in the medical group over the study period of 60 months or 5 years. In the surgical group, that's a very much larger figure, around 35% reduction in the need for insulin. And if we look at these patients in terms of who requires 2 or more therapies, starting off in the medical group, around 90% of them needing 2 or more therapies, getting down to about 75%. But in the surgical group, you've got a drop of about, dropping down to about 60% from 84%, or dropping, a reduction by roughly 50%, which is, as you can see in a randomized controlled trial, quite remarkable. So is weight loss surgery an easy way out? To my mind, no, it's not an easy way out. It requires a long-term commitment to change and changing your lifestyle. It's probably the most powerful tool we have to reverse chronic disease associated with obesity, and it's able to break the cycle of obesity. Not only that, it reduces long-term mortality and can put diabetes or type 2 diabetes into remission. It's also cost effective when compared to other treatments, and cost effective compared to the burden of chronic disease in terms of tax dollars. I believe within the next 5 years we will see obesity surgery becoming more widespread in the public system, and I welcome this. And in terms of conclusions for my talk, there's really little as clinicians we can do about the worldwide and Australian pandemic of obesity. And what we're really not seeing yet is the pandemic of chronic disease associated with obesity that we'll see in years to come. What we can do as doctors is we can provide change to individuals, and we can guide people through their journey of weight loss. And it's really only when you are able to sort of start the conversation with patients that this journey can begin. And I would just like to again reiterate the RAC GP advice of ask, assess, followed by advise, assist and arrange. And that's the conclusion of my talk. Thank you all for listening.
Hi, Robert. We do have a question that's come through, and everyone's welcome to submit more questions. But the question that's come through from a GP is that nicotine is an appetite suppressant. Has the decreased smoking rate contributed to weight gain or obesity in the community?
I think it's fairly well documented that people gain weight when they stop smoking. I actually don't know the answer to that in terms of you know, any longitudinal data that suggests that with people stopping smoking, they on a population basis, they're gaining weight. I know in the short term that is very well observed, and you probably do observe that in your own patients. Although the smoking rates are decreasing, smoking still plays a very high cost on chronic disease, and I don't think there's any situation that you would advise patients not to stop smoking.
Perfect. Well, that's the only question that's come through. If more come through, I might be able to send it through to you and get a written response for attendees. But thanks for your time, Robert.
Okay, thank you.
We'll move on to the next speaker tonight, who is Dr. David Joseph. And Dr. Joseph is speaking on surgical options for obesity and diabetes. So welcome, Dr. Joseph.
Good evening. Thank you for allowing me to present and talk to you all tonight. I'm sorry I can't see you all in person, but thank you for attending in this unusual format, and I haven't presented in a non-live forum before. I'm continuing on our topic of weight loss and metabolic surgery, and I'm going to be speaking on surgical options and outcomes. So what are the actual procedures that we perform? How do we go about them? And I'm going to also talk about patient selection, who you would offer surgery for, in what circumstance. Some outcome measures through the Australian Bariatric Surgical Registry, and then a couple of case scenarios of real patients and what we chose and how they've done. So there's a couple of surgical procedures that you may have heard of and be familiar with, certainly gastric banding and sleeve gastrectomy. A variety of gastric bypasses, including mini gastric bypass and Roux-Y, although a mini gastric bypass we'll talk about is becoming sort of more predominant. And then there's some newer procedures such as a SADI, which is a modernized lower risk version of a duodenal switch, which was kind of like a horrific procedure from the past. So who actually is currently indicated for obesity surgery? Well, in general, it's class 3 obesity, BMI 40 or higher, or BMI class 2, which is 35 to 40, with an identifiable comorbidity, usually related to or due to that obesity. Obviously, diabetes, hypertension, sleep apnea, degenerative joint disease, arthritic pain, etc. Interestingly, there's one of the studies that Dr. Gandy mentioned, that randomized study looking at severely or poorly controlled diabetics, medical management versus randomized 2 different arms of surgery. Those patients had a BMI of as low as 27, which shows that this can also be viewed as a metabolic surgery and they're not particularly obese, and it really does cure or well manage their diabetes. In Australia, in the last year, this is data from 2019 through the Bariatric Surgical Registry, which probably captures about 70 to 80% of all bariatric surgery in Australia. There are over 21,000 procedures, 70% were sleeves, almost 20%, and which is an increasing number, it's almost doubled in the last 10 years, is some form of a bypass. Very few bands are performed now, and there's of course a number of revision procedures which we won't really go into today. And the kinds of surgery are restrictive, so they either do something to the stomach that will limit the amount of food that can get in, and that's either a band or a sleeve, and we'll have a detailed look at that, or some form of malabsorptive procedure. So in other words, delivering the food somewhere down the intestinal tract that will limit the length of intestine and the variety of intestine through which you can absorb food, and that's a bypass or a duodenal switch. And then there's a range of restrictive and malabsorptive procedures, which can include the more modern bypasses, a mini or single or omega loop gastric bypass, and the newer SADI procedure, which incorporates a version of a sleeve with a duodenal switch. The surgery is all laparoscopic. It's a short length of stay in hospital. It takes 1.5 to 4 hours, depending on what's being done, and the patients generally stay in hospital for 2 to 3 nights and can usually get back to work within a week or less if you're doing sedentary work, or they might require a few weeks off work for more industrious labor so that the abdominal wall gets to rest. There's usually a clinic approach with a number of health professionals involved in the assessment and ongoing management of these patients, which incorporates a dietitian, a surgeon, and often a practice nurse or GP physician working within that clinic. There can also be other doctors, such as endocrinologists and psychologists, involved at times. But I think it's also very important, although not directly involved in the actual clinic process, the pre and post care involved with their own physician. I mean, as GPs become more familiar and comfortable with helping to manage these patients, and hopefully this talk will give a greater understanding, because I think although we like to see patients on an ongoing basis to reinforce the long-term changes that Dr. Gandy talked about, I think there is a huge role, and probably a more preeminent role, for GPs being in a better position to do that, although we don't want to stop doing what we do. Gastric bands are not really performed that much anymore. Probably 15 years ago, more than 90% of the procedures in Australia were probably a gastric band. What was good about it, you could go home the next day. It was potentially reversible. So if you go in, get in laparoscopic surgery and remove the band, you're almost restored to normal, particularly if you then take the effort to remove all the scar tissue that lies underneath the band. And it's I think, a more polite form of wiring your jaw shut. I mean, really, it really limits the rate and the type and the volume of food that can get through the upper portion of the stomach. The more modern bands that came around about 20-25 years ago had an adjustable inflatable cuff facing inwards towards the stomach, and that could be inflated a bit like through a port, like a portacath. You could add or subtract a few mils of sterile solution, thus adding or removing restriction. The downside, probably 10% of people did really, really well, 40% did okay, and a whole bunch of people didn't do very well. And the price you paid was terrible quality of life, very poor quality of food. You couldn't eat much solid food, lots of retching and vomiting, and high rates of reflux. And we even see patients many years down the track now having to remove the bands from other clinics from years ago, patients presenting with recurrent nocturnal cough, poor dentition, etc. So very limited cases are being done like this, of this nature nowadays. Again, just to go through mechanism, I mentioned the pros. It's simple, it's reversible. We don't interrupt with malabsorption. We're not removing any tissue. And then the disadvantages, it's not as effective as other more modern procedures. There's a huge variability in excess weight loss, bad reflux, intolerance to food, and a small percentage would have more catastrophic problems such as infection, band erosion, or herniation of stomach above the band, leading to large volume and potentially an acute surgical situation at times. Sleeve gastrectomy, currently in Australia, probably more than 82% of all procedures being done in Australia are now sleeve gastrectomies. It's very efficacious for a great number of patients. 20% of people probably don't do so well with them. It's hard to predict who is in that group. There are a range of assessment tools that you can make to try and pick that. Basically, all the surgery is pre-pyloric, so there's a pylorus and the duodenum is beyond, and effectively we're going to remove 60 to 80, 85% of the volume of the stomach. We're also removing a lot of the leptin and ghrelin producing cells from the fundus of the stomach, and patients will report that for about 9, sometimes 12 months, they have a much reduced appetite. They particularly don't feel like anything rich, sweet, fatty, which is of great benefit for them to make those big changes required to make this work. Eventually, patients can probably eat a side plate of reasonably normal food on an ongoing basis. And just like the Swedish study showing a long-term maintenance of weight loss, the 80% of patients who do well probably do keep their weight off long-term. It's essentially a restricted volume, but over the whole stomach rather than at one point. Patients usually have good satiety and diminished hunger drive at least for a year. Many patients do well. We're not interfering with nutritional absorption, just a volume of food that can get in. Eventually, patients can tolerate pretty much all food choices with minimal longer-term nutritional deficiencies, although supplements are required in the first 12 months, definitely. What are the disadvantages? A degree of ongoing reflux in a number of patients, sometimes requiring ongoing proton pump inhibitors, occasionally needing revision surgery such as a hiatus hernia repair and or conversion to a bypass to reduce the pressure in the stomach and allow food to empty more easily and unload the esophagus. Occasionally, torsion or strictures can occur. A mini gastric bypass is becoming more popular and will effectively this involves the creation of a long, narrow pouch of stomach. Again, it's all pre-pyloric. That this long, narrow pouch in a number of patients can result in a degree of satiety. Effectively, the pouch is emptied into the intestine approximately 1.5 to 2 meters beyond the duodenojejunal flexure. So you're missing all of the duodenum and a length of jejunal absorption. And we're also missing some hormonal stimulation that takes place when food enters into the duodenum. It's particularly good for type 2 diabetics, especially if they're on insulin. It can reduce the requirement for insulin. The downside potentially is dumping syndrome because the pylorus here is no longer really regulating food passing into the duodenum, and the food can pass straight down into the intestine, and certain food groups can pass readily down, and there's a range of different dumping syndromes. But effectively, it can cause big fluxes in glucose and insulin and fluid shifts into the gut, and patients can feel quite ill, nauseated, tachycardic, sweating, and want to lie down after food. Doesn't occur with all food groups, but that is a price to pay for some patients. It's pretty reliable. Many patients do well. It's excellent for diabetes and particularly dyslipidemia. Many food choice, it's a quicker return to reasonable food choices probably than with a sleeve. The downsides, dumping syndrome. Stomal ulceration is where you get an ulcer at the joint between the stomach and the intestine. It doesn't occur that often. It particularly is a problem in people who are smokers, so we tend not to want to do this in smokers. But of course, the people who return to smoking, even occasionally, that's a problem. And of course, you want to avoid non-steroidal use where possible. Occasionally, bile, because this is a loop joint, the bile can come back up potentially if this pouch is not long enough in an appropriate orientation. You can get bile coming back up and potentially into the esophagus. Probably the rates of that is 1 or 2%, and supplements may be required in the longer term as we're inducing a degree of malabsorption. I'll briefly show you how this compares with a Roux-Y. This is an older operation where you had a smaller pouch. And of course, if you did a smaller pouch with a single loop, you'd be delivering bile right up into a small pouch. It was quite easy for bile to get into the esophagus. So we cut and bring up a loop of intestine up to the little pouch, and food can now pass down that and join the biliary fluid coming from the second part of the duodenum and mix with the food where it will start absorption. And essentially all of this proximal loop of bowel, the jejunum brought up to the stomach, doesn't absorb anything other than simple carbohydrates very well. You're of course not absorbing anything in the duodenum in the first bit of jejunum, and then we have a common channel beyond. This was a stable operation and it works reasonably well. The downside is the potential complications. Because we've got 2 loops of bowel, there's increased possibility of internal hernias, twisting, and an acute surgical situation, as well as, of course, stomal ulceration. And it seems as though a single loop gastric bypass tends to work as well or better in terms of weight loss. And many centers are now turning to do that instead of a Roux-Y, and will only convert someone to a Roux-Y if they're unfortunate enough really to get biliary reflux into the esophagus and get some sort of inflammation there. So again, it's very simple to the mechanism for a single loop gastric bypass. It's good, but not probably as good as a single loop gastric bypass for diabetes and dyslipidemia. Like a single loop bypass, it's potentially reversible. So we're not removing anything, we're just cutting bits and reattaching them. So with a great deal of work, you could return this to normal, but why you would do that, I don't know. And if you did, patients would gain weight. Again, dumping syndrome could be an issue. The surgery is certainly more complex, can take longer. And again, the supplement requirements longer term are present. This is a more a newer procedure. It's a modernized laparoscopic approach to what was regarded as a very aggressive and nasty operation in the past of a duodenal switch of bilopancreatic diversion. And effectively, what happens is the pylorus is present here, and instead of like as in a bypass, we're cutting somewhere in the stomach, we're actually now cutting in the first part of the duodenum. So this used to belong to the bit of duodenum. So this has been divided, and we're going to now allow the food path to enter into the jejunal ileal junction. We have a common channel that we measure from the appendic stump or ileocecal junction. We measure that back to the joint and we make sure that's 3 meters. If it's 2 or 2.5 meters, certainly patients can end up profoundly malnourished. Probably not as much of a problem when it's 3 meters in length. This is combined with a sleeve gastrectomy, either at the time, or this can be done as a second stage procedure down the track. And so if we're doing it as a first stage altogether, we don't do the sleeve as tight. So what is good about this operation? Probably you get less dumping or no dumping at all, reportedly, according to studies, because the pylorus is still regulating food into the intestine. Although patients can get diarrhea, they don't get all those other dumping symptoms of sweating and tachycardia and needing to lie down. You could get some looser bowel motions because of the shorter passage of food and more liquid passage into the colon. Some loperamide can slow that down. It doesn't seem to be as much of a feature with the 3 meter length common channel. Much less stomal ulceration occurs because it's not in the stomach. The joint is actually intestine to intestine. So you get a restricted volume and a malabsorption. The malabsorption is more profound than with the other procedures. You tend to need a lot more protein a day to be safe rather than with a sleeve or a bypass. It's much more reliable and a better degree of weight loss, but the price you pay is the malabsorption and having really to stay on top of the situation. It's unbelievably good for type 2 diabetes, even for patients who've required insulin therapy for more than 2 years. It can result in remission of that diabetes, whereas probably a single loop bypass would not work if you've been requiring insulin for a number of years. You can usually tolerate normal food choices because you don't get dumping syndrome and no ulcers. Fat soluble vitamins are difficult to absorb, protein, calcium, and iron. So you're probably going to need supplements of all those things long term. The surgery is moderately complex, does take a little bit long, but it's relatively safe with a very low leak rate and complication rate. And these patients, we would only be selected if they were thought to be appropriate to have be compliant and willing to participate in a program in the medium to longer term, have regular 3-monthly blood tests to make sure biochemically they're safe, and were prepared to take supplements. Many overseas centers will not do this surgery on vegans or vegetarians because of fear that there's a more limited range of protein supplements and they just won't get to their goals. So what is the data like in Australia? We're probably over now about 89,000 patients in the Bariatric Surgical Registry. But you can see from just looking at this graph, down the bottom, the light blue is adjustable gastric banding, which really took off, and it's really plateaued and really essentially changed little over time. The big growth has been, in a huge way, sleeve gastrectomies, and to a lesser degree, gastric bypass. Very detailed slide. If you look at the top line, in the last year in Australia, 21,000 total procedures, 16,000 primary procedures, and revisions 4,000. So a number of patients are probably getting their bands removed, might be having a bypass or a sleeve. Females versus males, an enormous difference here. I don't know that this is a reflection of a difference in obesity between the genders, which there really isn't that much. It's just, I guess, social recognition, patients' preparedness to be referred, patients bringing it up with their GP. Perhaps you might have some feedback that you can give us. Is that the case, and how could we better address or bring it to men's attention as well, that this is a big problem? So 77% of patients are female having a primary procedure versus 22% of males. The average age is about 42, 43, similar to men and female, and the average BMI at presentation is about 42 or 43. Again, this is just a cumulative, this rather colourful diagram on the left shows just the growth in sleeve gastrectomies. The grey is the gastric bands falling in number, and their gradual increase in a range of the single loop or Roux-en-Y gastric bypasses coming to predominate. And then the purple is band reversal. So there's always a group of patients finally getting their bands removed. Again, this is again this diagram here. I'm not sure if you get access to these slides. I'm happy for all attendees to have my slides. I don't mind. But this just shows the change over time. So gastric banding at one point was 97% of all patients in the Bariatric Surgical Registry. In the early days in 2012, it was mostly a Victorian run thing, and there was almost a religion in Victoria about putting bands in, and no one else was really allowed to do anything else. So it didn't reflect what was necessarily happening in the rest of Australia. But certainly now, Australia-wide, 2% or 2.9% bands, 82% sleeves, Roux-en-Y and one anastomosis gastric bypass making up almost 19%, as we said. BMI at the time of surgery in Australia, class 3 or BMI greater than 40 is most patients, a significant number of patients, almost a quarter of all patients, that BMI 35. And then there's that other group that I mentioned, perhaps arthritis, sleep apnea. There's a group of patients who might have diabetes whose BMI is 30 or just under 30, who would also be appropriate for metabolic surgery to remit their diabetes. What percentage of patients actually have diabetes? So you'd probably be well aware of this, although the community seems to be ill-informed and think that all obese patients seem to have diabetes. In fact, 76% of all patients having bariatric surgery don't have diabetes. A number of patients aren't known, or at least not reported to the Bariatric Surgical Registry, but perhaps 25, 26% probably have diabetes. A lot of them might be diet controlled, and then there's a range of patients requiring various forms of therapy. There's some data here for 12-month follow-up for patients who had diabetes identified before and 12 months after surgery. And again, reflecting what some of the randomized data that Dr. Gandy presented, a big change in the requirement for any treatment or just the outcome and measure of diabetes. Do they have diabetes or not anymore? So a huge increase in the patients on no medication. Obviously, those patients used to be on oral hypoglycemic agents, on insulin, etc., and have greatly changed. So we can see a huge change in metabolic requirements. So it could be seen as some form of a cure or remission-inducing therapy for diabetes. Weight loss itself, 68.3% excess weight loss after 12 months from the primary procedure, 28% total weight loss, which is in keeping with Dr. Gandy, the data he's shown you. And that kind of keeps out for a number of years. And again, this year 3, year 4, year 5 data shows that yes, the long-term results are not as good. We'll be capturing much more data for 5 and 10-year data as the bariatric surgery registry continues, because there's only small numbers at 5 years being reported. But there is a degree of weight gain, but most patients have kept a great deal off, as you can see from the graphs. How risky is this surgery? So I said that it's a minimally duration surgery, laparoscopic, patients in hospital a few days, 2.1% adverse events for primary procedures in total. That includes blood clots, wound infections, delayed surgery, atelectasis, etc. So the number of patients who have a leak from a sleeve is probably about 1 in 300. Significant adverse events are probably about 1 to 1.5%. But again, the number of reported deaths as of 2018 is 75, but only 6 were related to the actual procedure. 36 not related and 33 were not back. So even if you included all that, maybe there's about 35 deaths out of 70,000 procedures. It's not a lot. Of course, you would rather it was 0. But if we look at the actual causes of death, where I indicated only 1 patient had a leak from a staple line, and everything else was fistulas, sepsis, or some sort of problem such as a PE related to having the surgery, and usually was bypass surgery. I've got 4 case studies, if I've got time, just to discuss with you that might indicate the kind of patients we see and the benefits they can get, and who might want to come and see us. Now, many of the patients I see, it's an interesting referral pattern, because some patients are referred because of discussion with their GP, but I would suggest that the ones I see are mostly driven by an eventual recognition that they want to change, bringing it up with their GP, or going to the GP, having talked with friends and family and saying, I want to do something. And some have particularly sought us out and asked the GP to refer to us. So this is a gentleman who came from a gastroenterologist who looked after him for a long time for ulcerative colitis. He'd been relatively stable with intermittent periods of steroid therapy required, usually per rectum. He was young but very large, and he actually he asked his gastroenterologist what could he do, because he was more worried about dying from his weight and limited mobility and shortness of breath than he was about his ulcerative colitis. And he required, he was on CPAP for sleep apnea. He'd had a sleep study. We eventually did a sleeve gastrectomy on him in October 2017. And by 1.5 years, he'd lost an enormous amount of weight. This gentleman was walking 2 kilometers a day in the first week, and eventually was able to walk 15 kilometers at a time, was incredibly motivated. And he actually expressed to me a genuine fear that he was worried about dying before he was 45, and it was probably not completely unfounded. His sleep apnea is completely gone. He's got increased energy. He's still very active, and he's probably now about 92 kilograms. Not ideal, a little bit overweight, but in a far different condition from before. Unfortunately, we didn't cure his ulcerative colitis. It's flared up from time to time and is still seeing his gastroenterologist. This is a younger lady I operated on early was it late last year? So she came to see me again. It's interesting, these younger patients, when you ask them why do they want to come and see you, they're actually worried about their health. And most of us who are 25 were never even thinking that we would die, let alone have a health issue. But these patients are genuinely concerned. They have trouble mobilizing, hygiene issues, showering, toileting, as well as the social stigma. And these patients often can't find clothes. They have to make their own clothes. And they are to a degree agoraphobic and don't want to get out. This woman chose to have a single loop gastric bypass, which was not unfounded. Probably patients over 150, 160 kilograms. It probably offers a slightly better longer term weight loss trajectory and maintenance than a sleeve, although that's debatable. So she had that procedure. She went back to the gym. She's pretty motivated. And when I reviewed her about 3 weeks ago, she was down to 119 kilograms, which is very significant weight loss in about 6.5, 7 months. And weight loss will continue probably up to about 15 months. So I expect that she'll get reasonably close to her goal, if not meet her goal. She's, of course, going to have a great deal of loose connective skin. We normally suggest they wait until that's occurred, weight loss has plateaued before they consider having that removed. This is a patient from this year, 36-year-old gentleman. He'd had a history of a few years of oral hypoglycemic controlled diabetes. He'd gained a great deal of weight and now required insulin therapy. His HbA1c, in spite of this, and you can argue that there was a degree of non-compliance and poor dietary choices, undoubtedly, his HbA1c was 11.4. He also has sleep apnea. He chose, after much discussion about options, and I really proposed to him that he should have a single loop gastric bypass or a SADI with the different risk profiles of each, and he chose to have a SADI-S, and he seemed appropriate that I discussed that with him, and he's compliant and he's been coming back, and he seems to be really good. Now, within a few weeks, he was off all his diabetes medications. He's not taking any medicines now. His HbA1c is now 6.6. He's lost a fair degree of weight in only 3 months. And his clothes size or his girth, I didn't measure it, but his pant size is already 48 down to a 38. And he says that's now starting to get loose around his waist. So he's doing really well. He works in a physical capacity at work. He's able to do a lot more without any shortness of breath. So that's a case in point and still progressing. And then the last, sorry, this is case 4. I didn't relabel that. That's a young woman who'd had many attempts at pregnancy, did manage to have some embryos stored, frozen. She'd gone through about 5 implantations, failed to proceed to maintaining a pregnancy. She was morbidly obese. She was actually suggested by her fertility specialist that she should consider losing weight. She wasn't necessarily recommended to have surgery, but she did eventually come and see me, and I wasn't made aware of her fertility issues until quite late in our consultation, because she just wanted to talk about her weight and should she have surgery. And as many of the issues I talk about with female patients, amongst them is potentially improved fertility, and it may help but not guaranteed to. And then she brought up her history of fertility. So it was very gratifying to hear that she's done so well. So she had a sleeve gastrectomy in late in 2018. I reviewed her in July 2019, and she'd essentially almost already reached her goal. So she'd done extremely well. She was very motivated, really engaged in exercise at an early stage. She's a fellow health professional. And then earlier this year, she wrote us all a lovely card, and she's now 4 months pregnant. So she's extremely happy. And this is not a single tale. There's many patients with this. And it's probably a reasonable point just to mention that we've had some GPs who've said, hey, this patient's pregnant, what do I need to do? We normally advise that patients should absolutely not get pregnant after any bariatric surgery for 6 months. Probably wait till 12 months, but probably after 6 months, they might manage to healthily nourish a growing fetus. They should just be under the direction of their midwifery clinic or obstetrician. Eat what they feel appropriate to eat. They'll feel like eating more. Their stomach will empty more. They should take plenty of protein and fertility vitamins, pregnancy vitamins, as well as their normal vitamin requirements. Almost all patients I see pre-op are vitamin D deficient. It probably doesn't improve or magically get better afterwards, so they should be on vitamin D, plus probably a good multivitamin. But certainly after 12 months, it's not an issue at all. We have, of course, had patients who, in spite of all our advice, do get pregnant within 8 weeks, 3 months. They've all done okay, but they really have to work hard. And I think if they get pregnant before 6 months, we certainly want to be involved in helping to guide, and our dietitians guide them to a path to good nourishment of growing fetus. So the summary, bariatric and metabolic surgery is effective. You get significant improvement in health parameters, improvements in quality of life. There's a pretty good safety profile, and metabolic surgery may be the best treatment for type 2 diabetes mellitus, particularly poorly controlled type 2 diabetes mellitus. There's no ideal procedure, but a range of procedures that should be considered as most appropriate for each patient, as discussed with the clinic. So thank you very much for listening to me.
Hi, David. Yeah, we have some questions that have come through.
Yep.
So the first one is whether the only advantage of bypass surgery is greater weight loss.
Look, the data shows that it might be slightly better at weight loss. So it's really difficult to tell, because overseas in Europe and the US, the sleeve gastrectomy that they do is different than the one we do. So they really do call it a vertical sleeve gastrectomy. They basically just cut straight down the greater curve without coming down towards the pylorus. So we actually come within 2 or 3 centimeters of the pylorus. So there's less possibility of that restretching. So I think the data that we have probably shows not that much difference in terms of longer term weight loss. What other advantage? Probably it's better for diabetes and for it's better for diabetes. It's better for dyslipidemia, probably. It's also associated with less reflux. So if someone has a history of Barrett's esophagus, of reflux of some sort, it's probably sensible to do a bypass rather than a sleeve. Although there's some interesting data. There's a surgeon in the Gold Coast who's actually doing a prospective study on people with Barrett's disease esophagus, but no dysplasia, so no cellular dysplasia there, and monitoring them. And 40% of that gets better, 40% doesn't, and 20% gets worse. But he's monitoring them and then converting them to a bypass if it gets worse. So, but the rest of the world thinks that you shouldn't do a sleeve if there's Barrett's. So if there's reflux pre-existing, a lot of it can get better with a sleeve, but depending on what it's like, you might prefer to do a bypass.
Great. The next question is regarding case study 4. So for your pregnant patient,
Yep.
Would she get her weight again after having the baby or during the pregnancy?
So the data, I actually gave a talk a few years ago at in the private hospital there on behalf of the Royal Hospital for Women to some GPs, and it was on fertility and weight loss. And I got a lot of data from Royal College of Obstetricians and Gynecologists, and they've looked at this. Now, the average weight gain for any woman who's pregnant is 10 to 12 kilograms during a full-term pregnancy. Of course, there's a huge variation, and we've all seen the patients who put on like 30 kilos, and how does that happen? But there seems to be little difference in weight gain as a total weight for those patients who've had bariatric surgery, and most of them can get back to where they were. And of course, the single best thing to engage in afterwards is breastfeeding if they can. But it doesn't ruin their weight loss, and they do get back on track. So the answer is they should not be discouraged from getting pregnant, and there is a fear amongst some women that they will put weight back on with pregnancy and not be able to lose it, because so many of them report a history of gaining weight with previous pregnancies. So I certainly appreciate that, but the data doesn't support that happens.
The next question is, if a patient has had a lap band that's been in for 20 years, which isn't working, should it be removed?
They should probably have an endoscopy if it's been there for 20 years. Some patients can get silent reflux and get some distal esophageal changes. They can get a dilated esophagus. It's a good question. If it's not causing a problem, does it need to be removed? I don't know absolutely that it does, but probably patients should have an endoscopy. If they're getting anything like any form of reflux, a nocturnal cough, some poor dentition, there was a patient, I think a year and a half ago, that came to me with a band, but they'd recently been started on nebulized Ventolin for new onset asthma, and they were like 55 years old. And I ended up deciding to have a look down, and they had an enormous esophagus, a very tight band stricture, and I just asked if I could take all the fluid out of the band, and the nocturnal, the pneumonitis or whatever it was happening was gone the next day. So symptoms, yes, and that otherwise an endoscopy, but otherwise I don't know that you absolutely have to remove it. I don't know, it would be interesting to see what my colleagues' thoughts are on that, but I don't say absolutely yes.
The next question is just whether you can expand briefly on the assessment tools for who would and would not suit a sleeve gastrectomy.
Well, you can see from the Australian data, it seems to be throw a dart at the dartboard, and if it lands, that person gets a sleeve gastrectomy. It doesn't matter if you're very accurate or not. So, the data shows that 83% of people get a sleeve gastrectomy. So it's almost like everyone is appropriate for a sleeve gastrectomy, except those who might benefit from a better procedure for the disease they have, like bad diabetes, or if they've got reflux, consider a bypass. So I don't see who doesn't benefit from a sleeve gastrectomy in a way. It's reasonably well tolerated. And we always see the patients who do suffer from reflux, but so many patients we follow up, no, I don't have it, I don't have it. But the ones that do have it, it's really an annoying procedure. And of course you can manage that eventually with a bypass conversion if it's really bad. So for my practice, although I do all these other procedures as well, I would probably say 80% of my patients have a sleeve. And the patients who don't, I either medically recommend they have another procedure or they've chosen to have a bypass because they know family who've had it and they're prepared to put up with the issues associated with that.
Great, and the last question is just whether you can talk about the requirement of supplements following these procedures and if you have any recommendations.
Okay, so patients non-SADI procedures, so like a bypass or a sleeve, those patients should, in our program, have a year-long program of a multivitamin every day. Ensure that they also have a vitamin D, as there's often and not enough vitamin D, but sometimes they'll need more than that, as directed, what we've identified pre-op. They should also aim to have some protein supplements, specifically aiming for 50 to 60 grams a day of protein intake. The first 3 to 6 months is a real challenge in terms of getting some form of animal or vegetable protein in, so they probably need supplements several days a week, if not every day. And there's a variety of formulations, including types of protein water. They can buy protein powder like soy or whey powder that bodybuilders use, and you can make that into a smoothie or put it in a soup or cooking various things, a stew that they might make. So people do manage. Some women complain of hair loss, and we have looked at a whole range of things, in zinc and copper, manganese, selenium, anything you can think of. We've looked to see if there's a deficiency, and there's a whole lot of vitamins available that people go and buy, hair and nails and body. But the single thing shown to limit hair loss, particularly for the women, is protein supplements. And so many of them who are having hair loss are probably not keeping up with their protein intake, and that's particularly evident, or at least the ones I talk to. So that's what they need initially. Probably longer term, you want to keep an eye on iron and protein in terms of the bypass patients, occasionally calcium, but not usually. So we will usually monitor, and in our program, we usually do a blood test at about 10 to 12 months for a sleeve patient, because we don't often see a deficiency before then. A bypass patient will do it at about 6 months, and a SADI at 3 months, and every 3 months thereafter. The only exception to that, if someone has diabetes, no matter what procedure they've had, I'll usually do a blood test within 3 or 4 months to see how their diabetes management is going.
And we just have one more question that's just come through, and that is, what is the waiting time for these operations in public hospital?
Okay, so it depends on where you go. There are a range of hospitals that currently provide very limited access. They're all fed into by some publicly run patients. So if you want someone to access a publicly run program, then although I'm a doctor who provides some services at Concord looking after some publicly funded bariatric patients and I do some of the surgery, those patients don't come through my clinic in my office. They go through some clinics run out of RPA, Camden and Concord hospitals through different metabolic and obesity clinics there. There are also programs that I think Nepean and Blacktown, there have been at Sutherland and St George over periods of time. And again, as Dr. Gandy said, eventually there's going to become an impetus for this to take place. So the government just probably is reluctant to fund so many extra procedures, and they're passing the financial cost on to a future government, unfortunately, but the cost benefit is definitely there. So if you want your patient to access that, you just have to look up some of those clinics. The good side is it's completely Medicare funded. It's a great program. They have dietitians and psychologists and often exercise physiologists. The downside is it can take at least 6 to 12 months to get into the clinic. It can then take 6 to 12 months of participation in the clinic of various forms before you then might be considered for surgery. Concord Hospital, which I'm associated, has increased from 15 to 20 to 50 to now 60 publicly funded procedures a year, and it's likely to increase to 80 in the next year. And there's no reason why there couldn't be more procedures. There's a definite need and quite a defined benefit. So, you know, write to your local member or something, but that's the pathway for your patients to get access to those things.
Fantastic. Well, thank you so much for your time, Dr. Joseph.
Thank you.
I'll introduce our next speaker. It's our last speaker for the evening. So our next speaker is Dr. David Links, who is speaking on helping GPs troubleshoot weight regain and other post-op issues. So welcome, Dr. Links.
I'm assuming everyone can hear me. I'll just put my slides up. So thank you for the opportunity to talk tonight. And I'm talking about helping GPs troubleshoot weight regain and some other post-operative issues. There will be a little bit of crossover between what has been talked about already, but hopefully not too much. And I'll try and bring some practicalities into it. I'm also one of the bariatric surgeons at Prince of Wales Private. So the outline of the talk will take about 20-25 minutes. We're going to talk about a couple of long-term issues you might need to know about weight regain and pregnancy and bariatric surgery. So I wanted to start with a clinical case. And John is a 51-year-old man who's new to your practice. He's come to see you regarding heartburn and intermittent vomiting. He's had a sleeve gastrectomy 5 years ago in Perth. He got down to 91 kilograms, which is pretty good from 120 or so. And he's now put on 8 kilograms over the past year. He's had no follow-up for 4 years and he's never taken a multivitamin in his life. And he's recently moved to Sydney. So already there's a couple of alarm bells here. The lack of follow-up, the weight regain, vomiting is not normal after weight loss surgery. So if you're getting intermittent vomiting or more progressive vomiting, that needs to be investigated. So the 5 things I'm going to talk about are strictures, reflux, dumping, micronutrient deficiencies, and internal hernias. So strictures can occur with a bypass or a sleeve, and they can be acute at the just after an operation if the sleeve is too tight, or they can form with ulceration or after a leak later on down the track. You can see from this picture that the midpoint of the sleeve is generally where we tend to get narrowing and strictures, and we get hold up of food above that, causing reflux, epigastric pain after eating, and vomiting. The problem with the stricture is that people stop eating solid foods and they tend to eat liquids, which go through quicker. And when you eat liquid calories, that gets absorbed and you start to put weight back on. So generally investigation includes an endoscopy and a barium swallow, and what we're looking for is functional torsion of the sleeve or a tight narrowing. And on endoscopy, we want to look for ulceration and angulation and whether it's really tight. The management of a stricture is generally an endoscopy and dilatation, and we can actually dilate sleeves up to about 30 or 35 millimeters, and often that will improve people's symptoms. Worst case scenario, if it's a sleeve, you may look to revising a bypass to a bypass, or if it's a bypass, you might have to take down the joint and redo it. Reflux we've talked about a bit already, but I'll give you my sort of practical side of it. Much more common in sleeve gastrectomy than with a bypass. It can be associated with structural issues. So my advice would be, if you have a patient like this who's getting progressively worse reflux, you should refer them back to their surgeon for further consideration. We know that after a sleeve gastrectomy, in the first few months after surgery, people can get esophageal spasm, which is that tightness just after eating. That is not reflux. Sometimes that can be improved with buscopan or peppermint oil, and generally that tends to get better with a little bit of time. Often people who have true reflux, it's worse at night time. They can wake up in the middle of the night with reflux. Generally, we investigate again with an endoscopy and a barium swallow. And what we're looking for on the barium swallow and endoscopy is whether they have a stricture, whether they have a hiatus hernia, possibly the sleeve has slid back up into the chest a little bit if they did have a hiatus hernia repaired at the time of the operation. And the management, similar to other reflux cases with a native stomach, is we start with PPIs, Gaviscon, dietary adjustments, smaller meals, not having big meals just before bedtime. We do an endoscopy and we might dilate a stricture if we find one. If reflux is really troubling for a number of months and the PPI usage is increasing, then we might look at repair of the hiatus and pexing the esophagus and the sleeve back down if need be. And worst case scenario would be conversion to a Roux-en-Y gastric bypass. It's worth noting that with a single anastomosis gastric bypass, because it's a loop, we are delivering bile up into the gastric pouch. So people can get bile reflux with that operation and very rarely have to be converted over to a Roux-en-Y gastric bypass. We talked a little bit about dumping already, and everyone knows that sort of history of dumping, and especially the bypass patients, doesn't tend to happen with sleeve patients, but the bypass patients know if they've eaten the wrong things, very simple sugars, half an hour after they've eaten, they feel very unwell, sweats, crampy pains, diarrhea, sometimes vomiting, and that's related to those rapid fluid shifts with the hyperosmolar simple carbohydrates. Late dumping, which is occurs 3 or 4 hours after a meal and is more related to an insulin spike and then hyperinsulinemic hypoglycemia, tends to present sometimes with those symptoms, but also with neuroglycopenic symptoms, so blurred vision, poor concentration, and even a coma if it's really, really bad. So what I would say from the GP's perspective about dumping is this is all about what they're eating and their food choices. And most of the bypass patients learn this pretty quickly and they avoid it themselves, but sometimes they need to be told. You need to tell them to have small, regular meals. They need to decrease the simple sugars that they're eating, and they need to eat more complex carbohydrates and protein. And the other thing they can do is eat their solids away from when they're drinking their liquids, and that will make a difference. Generally, if you're having a lot of trouble with dumping type symptoms, the first thing to do is refer them back to the bariatric clinic, and the dietitian will sit down and talk through things with them. And most of this can be dealt with in that way. We talked a bit about micronutrient deficiencies. I'm not going to tell you about how to replace them, but I think this is about process more than anything. And I see there's sort of 4 main steps about how to avoid this problem. And that's in the preoperative and in the postoperative phase. Everyone who is looking at having weight loss surgery or metabolic surgery should have a preoperative micronutrient screen. And David Joseph's already mentioned some of the things that we look for: B12, iron, folate, vitamin D. At least a third of patients who are having weight loss surgery will be micronutrient deficient before they have surgery. So that needs to be replaced beforehand. The next thing is we need to educate the patients, and that comes down to us as surgeons, the dietitians, but also I think there's a role in there for the GP. I'm a bit different to David. I don't think there's any harm in telling these people that they should have a complete multivitamin every day for the rest of their life. I'd rather err on the side of caution And the common ones we might say something like a Centrum Advance or the NutriTube Band Buddy, but generally the dietitians will give specific advice to individual patients as to what they think is the best one for them. And they need to understand that it is their responsibility to take that every day for the rest of their life. So one thing you could say about the case study at the start of this is that it would be a good opportunity there to just repeat his micronutrient screen and start him on a multivitamin. I think these people should have their bloods checked annually, and then we add on specific supplementation when required. If you think about micronutrient deficiencies, part of it may be due to reduced intake. Part of it is because we're bypassing parts of the bowel that absorb these things. Part of it is because we're taking a large part of the stomach out and they're producing less acid, so they're less able to absorb iron, for instance. David did say already that bypasses generally can have issues with fat-soluble vitamins, so we need to think about that. I would say that it's probably you're better off just arranging an iron infusion if people are having real trouble with lethargy and poor concentration and anemia after bariatric surgery, rather than trying to push the oral tablet intake. We know that in pregnancy after weight loss surgery that these people need more than the normal amount of folate you would take as a pre-pregnancy dose, so up to 5 milligrams a day. And then the last thing I would say is that we always need to be just careful to look out for symptoms and signs of weird deficiencies. So particularly with bypass patients, thinking about neurological issues and which can be related to B12 problems, thinking about lethargy and anemia, thinking about vitamin A and sight difficulties. These are the things sometimes you might not necessarily check for these routinely, but when you see a bypass patient who is unwell for some reason, it's worth thinking, could there be a micronutrient problem going on here? And the big one is really ongoing vomiting after a sleeve or a bypass, and particularly those people that are vomiting because of a stricture or some other problem and are presenting to hospital. You have to be thinking about thiamine deficiency, and that needs to be aggressively replaced, or you can suffer from a Wernicke's encephalopathy. What I would say is that if you're having any trouble with this, do refer back to the clinic dietitian. The fifth thing I wanted to talk about was internal hernias and bowel obstruction. This is a problem really unique to gastric bypass, more for Roux-en-Y gastric bypass than for the single anastomosis gastric bypass. And you can see when we basically rejig the anatomy here with a bypass procedure, we create some holes in the mesenteric defects or holes in the mesentery where bowel can slide through and cause an obstruction. Now, this can be a chronic problem with intermittent abdominal pain, or it can be a severe problem with peritonism, sepsis, perforation. Vomiting is not always present in the setting of a closed loop or a small bowel obstruction with an internal hernia. It's worth noting that a CT scan won't necessarily always pick this up. So if you have someone who has had a bypass, who has severe abdominal pain or recurrent pain that's not getting better, they need to either be sent to emergency or be referred rapidly to a surgeon. And often the only thing that will truly diagnose whether or not this is going on is a laparoscopy. The second part of my talk, I wanted to talk about weight regain after bariatric surgery, and we've covered a little bit of this already, but I wanted to talk about maybe some practicalities. I tell people who are having a sleeve gastrectomy that there is a 20 to 25% chance of them having significant weight regain after this operation. And that doesn't mean that they will regain the weight back to where they were necessarily, but it's meaningful weight regain. It's a little difficult because there's no uniform definition of weight regain in the literature. There's lots of different variations reported in different studies. But I think what does matter is setting reasonable expectations as to what their weight will do long-term after weight loss surgery. And does the weight that they are putting back on make a difference to the patient, and is it impacting on their comorbidities? If you look at the natural history, of weight after bariatric surgery, and this is a big cohort study of thousands of patients looking at Roux-Y gastric bypass, sleeve gastrectomy, and the gastric band. Again, it mirrors what we've seen before. Most people having a Roux-Y gastric bypass drop about 30 to 35% of their total body weight over that 1 year period. And then they'll slowly put on about 7% of the original total body weight over about 5 years. That is a normal result. Same for sleeve gastrectomy. They drop to 25% of their total body weight and slowly put on about 5 to 7% over 5 years. What we saw from the data that Dr. Gandy presented originally, though, is out to 20 years on the Swedish obesity study. Generally, they found that this now stabilized. We can see the results from gastric bands much worse with regards to total percentage weight loss, and that's why bands are not generally done much anymore. It's also worth saying that this really does mirror what people's weight gain is in the non-surgical population. We do start to put on a kilogram here, a kilogram there over our life from our 20s through to our 50s and 60s. There are a lot of factors contributing to weight regain. We talk about calories in and energy expenditure, and that is important, but there are other things that Rob alluded to, as well as the obesogenic environment that we live in and behaviors that we carry out that contribute to our weight. Genetics is important, and the underlying epigenetics that's driving weight regain over time. And then we've got the background of hormonal pathways driving both putting weight on and losing weight. GLP-1 on one side, ghrelin, as we've said before, which is reduced after a sleeve gastrectomy, drives weight regain. And these are even simple things like the environment where people are working. If they walk to work, I tell people they should try and walk to work if they can. If they're walking to work and they walk past a McDonald's every day, and they used to go to McDonald's every day before their weight loss surgery, inevitably a lot of these people will start going back to fast food if it's there in front of them. So those are the impacts, the things in the environment that can impact on your weight long term. Another way of looking at it is just breaking it down into, and this is one of the GP publications, anatomical issues can contribute, and we all know about the gastric sleeve that can slowly dilate over time. And it starts off at 100, 150 mils, and then before long it's 300, 400 mils, and we can do a special CT scan to measure the volume of a sleeve. And obviously those people are not going to get the same restriction that they had previously. But I would say not everyone gets a really dilated sleeve over time. There are physiological differences that lead to weight regain, psychological and behavioral challenges. It is important to note that there are physiological adaptations after weight loss surgery. For instance, adaptation in the mucosal lining of the small bowel and its ability to absorb things, that is unrelated to behavior and is very difficult to overcome through behavioral change. So how are we going to actually address this with patients? I like to think of what can we focus on that are modifiable factors, and understand the non-modifiable factors, but we're not going to try and change them. Modifiable factors that I tell patients, these are the things you can focus on to avoid weight regain after you have lost your weight. Things like sleep patterns. So we know that people that have night shifts and night jobs tend to put more weight on, tend to graze at night time, and their eating habits are not as good. And that impacts on people who are shift workers, like nursing staff, for instance. We know if you perform a significant amount of physical activity most days of the week, you are less likely to put weight back on, and that's a combination of aerobic exercise and weight resistance-based exercise. So I tell people they need to find the things that they love doing and get back to them, and they need to do something every day. Sorry. We can modify eating behaviors, and that's through education, obviously primarily through the dietitian, but we can reinforce these things. We can modify what medications they're on. We know that antipsychotics play a big role in people putting weight on. We heard already that things like some of the diabetic medications can influence this, and steroids, and we can modify anatomy. stress and life events do lead to people putting weight back on. So what advice can I give patients when I'm seeing them in the rooms and they're saying, oh, I've put another 5 kilos on? I tell people that obesity is a chronic condition. There's not a single fix for this problem, and it provides a lifelong challenge. I think it's important to reassure them that there are many reasons for weight regain, and this is not about failure or blame. I think it's important that they re-engage with their weight and their food choices and their behaviours. And often this can easily be done by referring them back to the bariatric clinic. At the clinic, what would normally happen is the dietitian would see them and they might do a 3-day food diary, talk about their food choices, review their food choices and see where they can tighten things up. Often after a couple of years, people are starting to sneak some sugar back into their diet and drinking other liquids other than water, and we want to try and limit those excess calories that they're taking in. They might see the surgeon to rule out a structural issue. And then there are a couple of things that as a GP you can also be involved in. One is suggesting people go back on a very low calorie diet for a couple of weeks, 2 to 4 weeks, usually with supervision with the dietitian to try and kickstart some weight loss. We can add in meal replacements on a daily basis. And there's reasonably good evidence now that adding an early adjunct of a weight loss medication in people who are starting to put weight back on after weight loss surgery can have a really significant benefit. It's important to reinforce the rules of success. This is never going to be easy. This is hard work, but they need to break some of their old habits and they need to follow the rules. I just wanted to talk briefly about revision surgery after weight regain. I think if you're talking about revision surgery because people are putting more weight on, it's really important to tease out why they might have failed to lose weight in the first place or why they are regaining weight. There's no point doing these operations if you don't understand some of the drivers underneath this as to why it's happening. We should be trialing non-surgical interventions first, re-engaging with the team. There are many options for revision weight loss surgery, and this comes down to a tailored discussion with the patient as to what might be best for them. Often with a failed band or a band that's causing problems, people may revise that to a bypass in the current setting, or a single anastomosis gastric bypass, which has a slightly lower leak rate than doing a band to sleeve. From the perspective of risk, we know that the acute risk is 3 times as great with revision surgery, so this shouldn't be undertaken lightly. We also know that the outcomes with regards to weight loss and other comorbidity resolution are generally less successful than in the primary procedure. I would say if someone has had a band, they've done well with that, and then the band has been removed because they've had a slippage or some other acute problem, I think they've proven that they've done reasonably well with a procedure, and they're probably going to do well again. Generally, we try to pick a different style of operation. So if you've had a restrictive operation initially, you might look at a malabsorptive operation as a second procedure. Some people are resistant to weight loss surgery. And then the third thing I wanted to talk about, we've covered a little bit already, is pregnancy and bariatric surgery. So another case study, Lucy's a 35-year-old woman. She's been thinking about weight loss surgery. She's BMI 38, she's got insulin resistant polycystic ovaries, and she's been having trouble conceiving for a couple of years. And usually what's happened is these people have been speaking to their friends or their obstetrician. It's got in their head that it might be a good idea to think about weight loss surgery to improve their likelihood of conceiving. So they might come to see you and say, is this a good idea? And is this going to get in the way of me trying to conceive moving forwards? So there's 5 main points that I wanted to make about this, and there are some really good guidelines, so consensus recommendations around this published last year in obesity reviews. The first is that there's strong evidence that obesity does improve complications for both maternal and fetal complications during pregnancy and also during childbirth. And a great example of that even is just talking to the anaesthetist who are trying to do a epidural or spinal anesthetic for someone who's in labour, and how difficult that can be in someone who's 130 kilograms. The second point is that there is good evidence that weight loss surgery can improve fertility, although, as David Joseph said, this isn't guaranteed. I wanted to talk a little bit about the choice of operation, and I think generally we would go for a sleeve gastrectomy in this setting. It basically has a lower risk of malabsorptive type problems. There is evidence that people can suffer from internal hernias during their pregnancy, and it is really difficult to manage these sort of complications when someone is pregnant, because you can't easily do imaging. You can do CTs and MRIs, but it's all about balancing the risk of radiation and the unknown risk, I guess, of MRI, which concerns some people with the information we're trying to get. We don't want to operate on these people if we can avoid it. So generally we would err on the side of a sleeve gastrectomy if we're talking about a fertile age woman who's trying to is looking at childbirth in the future. Fourth point I want to make is that we really do need to make a plan around this, and the guidelines, and I would agree with that, is that we need to delay pregnancy until at least their weight has stabilized, and generally that is about 12 months. There needs to be a strong plan in place before they start trying to conceive with the dietitian, the GP, and their obstetrician, I would suggest. We need to do a whole raft of the normal pre-pregnancy micronutrient screens. I mentioned before that people do need an increased folate requirement after they've had bariatric surgery. The guidelines would suggest that you should have dietitian supervision every 3 months when pregnant to ensure they're, as we talked about before, getting enough protein in and providing adequate nutrition. And the other thing the guidelines do suggest is that there is a small risk of growth retardation in this group, and more frequent fetal growth scans, ultrasound scans, should be done. And as David Joseph said before, if you do get pregnant within 12 months, this is absolutely not a disaster. It can be managed, and lots of successes in this case. The final point is that contraception is really important around bariatric surgery, and we should be counselling people before surgery about options regarding this. We know that there's not an absolute guarantee of the absorption of the oral contraceptive pill, so this shouldn't be used in people who are trying to maintain contraception after bariatric surgery. It also has the potential risk of increasing DVTs, and other options such as long-acting reversal contraception, such as the Mirena or the Insulin, would be more recommended in this setting. So, in summary, there's a few keys to long-term success, and it really is about a team effort and providing a supportive environment for these people going through this major life-changing surgery. I think it's really important to set realistic expectations, and that goes down to saying, what are we expecting your weight to do over the next 12 months? What are we expecting it to do long term? What do you need to do to achieve that? So the education is key. There are many facets to achieving and maintaining weight loss, and the education comes from a number of sources: the GP, the surgeon, the dietitian, the psychologist, support groups, exercise physiologists, and personal trainers. And it's important to re-engage the right person at the right time. This is just pick some examples of things that we can talk about when we see patients that I think is important education. When we talk about diet, it comes down to even things like, right, okay, when you're eating your food choices, what foods are you going to eat first? How much protein are you going to have on the plate? Are you going to chew? You need to chew your mouthful slowly, enjoy the food, take a minute, talk to the people around you, swallow that, take a minute, and then have another mouthful. Use a small plate. And it's going to take you 20 minutes to eat a small entree-sized meal, rather than some of the behavioural sort of habits we've had in the past of just wolfing our food down to go on to the next activity. The psychologists talk a lot about mindfulness around this. We need to educate people about the benefits of exercise to maintain weight loss, and also the improvement in quality of life they get when they become more active. We need to set some concrete goals around how many calories should you be eating each day if you want to achieve the results you're looking for? And how do we do that? We need to tell them that sleep and routine is important. We need to give them the confidence to weigh themselves regularly, not necessarily every day, but weigh themselves regularly so they do understand when they are starting to put weight back on and they need to tighten things up. And we need to tell them about alcohol having a significant amount of calories. We need to tell them not to smoke because that increases their risks. We need to tell them to drink water. So if we go through this path of working as a team to educate people about what they need to do to achieve the goals they're looking for, then we can generally be successful. Thank you. Are there any questions?
Hi, David. Yes, there are a few questions that have come through. The first one is, how much are people out of pocket on average for each procedure and a year of team support?
Interesting question. I think what I'm going to tell you, I think, is a broad sort of range. I think it depends really. It comes down to whether people have private health insurance that covers weight loss surgery, and certainly many people wait 12 months and increase their insurance to do that. Generally, if you see most bariatric surgeons and you have private insurance that covers bariatric surgery, the costs, including a program with set follow-up, and most places would have that. And I think if you're sending people somewhere where they don't have a follow-up program, then you should look elsewhere. But the costs might range anywhere between $3,500 to $5,000, $6,000, $7,000. But that depends on a variety of things, including what operation they choose and how complicated they are, whether they're having revision surgery. If you don't have private insurance, then another option is to self-fund, and then you have a significant greater cost with paying hospital fees, and you have also the risk if you stay in hospital for a prolonged period that the hospital will then give you a bigger bill for that. And then the other option is to look, as talked about before, at some of the public options. And we have a public bariatric workup clinic at St George Hospital for our area. And as David Joseph said, at Concord, there's a similar thing. And obviously there's no cost in that, but the wait is significant.
Great. The next question is, what lifestyle advice do you give to patients who are shift workers and prone to weight regain?
I think it's about getting into routine. So as I said before, if they understand what they need to do, if they understand that even though and truck drivers are a classic one because they don't, they eat on the run, they stop at different places if they're doing long haul trips and they're sleeping rarely. I think they need to understand what they need to do to succeed, and then they can make the changes. They can plan their meals out ahead of time. They can take them with them. It's about awareness of this problem, and in doing that, then they can make the supported changes to overcome that. I'm not saying that happens to everyone who's a shift worker, but I'm just saying that these are the sort of flags where we think, right, okay, we need to work extra hard here to try and limit this being a factor.
The next question is whether there is an age limit on bariatric surgery and which one is better for older people.
So the answer is that the sort of older guidelines would say that 65 is the upper limit of who you should be considering for surgery. But I think there's good evidence now, and we've looked at that people in their late 60s and even early 70s who have reasonably good background health but are obese can safely have weight loss surgery and get real benefits from that. If you said, is there evidence that their mortality is reduced by having surgery, or that they have an absolute significant risk in stroke or heart attack and those sort of vascular complications, I think a lot of that data comes from younger patients. So I'm not sure that absolute evidence is there, but certainly we've had a number of people in that older age group who have had very successful outcomes with surgery and want to keep traveling. They don't want to be 130 kilograms in a nursing home at the age of 72. They'd rather be slimmer and at home and able to care for themselves. With regards to choice, I think you'd probably be erring on the side of a sleeve gastrectomy than a gastric bypass in that age group.
The next question is, how do GPs access the St. George Clinic for their patients? And if they don't take referrals from primary care, why not?
There is a referral pathway through the St. George Hospital website, it's my understanding. And it's, I mean, same as I'm sure the other area health programs in the state, and there's one in just about every area health network. That there's essentially a tick box format, which is very specific around, do people have diabetes or other complications like sleep apnea? Is their weight over BMI 35? Do they have any contraindications about alcohol abuse or drug abuse and other potential psychiatric illness? So my understanding is anyone at the current time can make a referral using that process. The problem is that the access to actual surgery is very limited at this time, and we're hoping that will increase over time.
Great, and the last question is whether public bariatrics is available at Prince of Wales Hospital.
Related to the previous discussion, the area has basically St. George, through the workup clinic, will provide a bariatric service to the area as it currently stands for public patients. We do some renal transplant, sleeve gastrectomy for renal transplant patients who are too obese to have a transplant because the majority of the transplant work is done at Prince of Wales. But if you're a GP within the South East Sydney Area Health Service, it doesn't matter where you are within that service. That clinic is set up to service our local area.